So am I okay like that?
So we're just going to count down. Voice of God is speaking to me. Great, well, we're delighted to have on the settee this time Professor Thomas Bardin, who, as you probably saw by his name, is from France. And I'm thrilled to have you here. You're on a whistle-stop tour, I believe, 5 days, 2 speeches every day. You must be exhausted, and this is the last one, and you're still smiling.
I'm fine, I'm fine, I love it.
It must be our good New Zealand wine in that case. Not as good as the French, but we're trying hard.
Oh, we are very good.
We are trying hard. I was introduced to you before as a gout professor, which certainly where we are locally is a very important job, really. There's a few questions I would love to throw at you, if that's all right. And
please do.
I think one of the important things for all of us dealing with Maori and Pacific Island in particular, as well as New Zealand per se, we have a significant gout problem in its own right. So I suppose the question is, what are we doing right, what are we doing wrong, and what could we do better in a nutshell for gout?
Well, I think that you have an important prevalence of gout because of the genetics. So you're doing nothing wrong.
So it's not our fault.
No, not at all, not at all.
I'm saying that it probably is, but thiazides and are we contributing towards gout by being old-fashioned with our diuretic use and that side of things? Are we contributing towards it?
I think that the diet contributes. In genetically predisposed people, the diet has terrible effects. And, but it's mainly the beer, the spirits, and the fast food. Because they get people to put on weight, and weight very much correlates with uric acid levels. So
if percentage-wise, how much is genetics and how much would be the diet, percentage? What can we tell our patients, reassure them or otherwise?
Well, I think that if you don't have the genes, you can eat whatever you want, and you will get fat, but you will not develop gout. But if you have the genes, then you cannot cope with the excess of uric acid which comes from the diet, because you cannot excrete uric acid enough through the kidney. So then you get chronically elevated serum uric acid, and then finally you develop gout.
And again, as prescribers, the old-fashioned guidelines were telling us to, as first line, give thiazide diuretics to the over 55s. Are they contributing significantly to our gout problem?
Especially in the women.
Right.
In the long-standing management of hypertension in women, yes, there is a significant increase in gout. But you should also weight the benefits of diuretics. So we'll see what the guidelines will tell us in the future.
Fair point. And as regards addressing this uric acid problem, I think we were talking before, we have the problem not only of symptomatic gout per se, but we also have that phenomenon of uric acid being an independent risk factor for cardiovascular disease. Could you educate us a bit about that phenomenon, that side of gout?
I think that gout is certainly a very important independent factor for myocardial infarction and for stroke. Asymptomatic hyperuricemia is also a risk factor, but less pronounced. You know, the problem is that we believe that uric acid, excessive uric acid is bad for the kidney, the heart, the brain vessels at least. But we do not have large intervention studies which show us that by lowering the uric acid, we will improve the cardiovascular prognosis. So we know the risk of drugs, but we are not sure of the benefits. So,
right. So the jury's still out on that one.
Yeah, but any agency will not indicate uric-lowering drugs in asymptomatic hyperuricemia if they don't know the benefit.
fair call. Now then, we is a very dynamic country, and we are importing people all the time, not only yourself, but we're importing patients. And a few of us have had patients who are telling us about febuxostat and its availability in Europe, and I'm mindful of the fact it's available but not subsidised at the moment. Is it a superior product? Should we be lobbying to get that subsidised? Could you teach us a little bit about this drug which our patients are telling us is available overseas more widely than it is here?
Well, you know, we've lived for 30, 40 years with allopurinol, which is a very nice drug, but which sometimes fails. And it fails even more nowadays that gout is more severe than it used to be in the 70s, where allopurinol was first introduced. And sometimes allopurinol is not tolerated, or the dose cannot be increased enough because the patient has a renal problem. So some of the patients are in a dead end, and we cannot cure their gout. So in these patients, febuxostat is wonderful, because usually it allows to get the uricemia target and to cure gout. So these are the patients intolerant to allopurinol and those with kidney disease. These are the two main indications in which febuxostat is clearly superior to allopurinol.
That's fantastic. We're getting a bit low on time. So really, I think the summary is then, if we take febuxostat, we can eat too much, drink too much, get fat, and thoroughly enjoy where we're going. And,
that's not exactly what I said.
Close. God bless you. I think we got what you said. I really appreciate you saying that too. Well, I really wish you have a lovely time in New Zealand. Thank you so much.
Thank you, sir.
Professor.
Bye-bye.
And there we have it. Thank you very much. God bless you. Thank you. That was great. That was lovely. Thank you very much. I really appreciate it. Oh,
you're very dynamic.
Well, thank you very much. Well,